Hi, my name is Annette Cuddy, and you're welcome to Inclusion Health podcast series. This is a follow-on of the Including Inclusion Health Voices from the Margins webinar series. And I'm delighted to be joined today by Anne Nolan. Anne is a research professor in the Economic and Social Research Institute, known more broadly as the ESRI, and we hear it on the radio and the television all of the time. And Anne is Research Area Coordinator for Health and Quality of Life Research at the ESRI. I don't know if I got that right, Anne, but you
did.
So, Anne, you're very welcome to the podcast today. And I suppose just as a start off, Anne, we all know about the ESRI, but you might tell us a little bit about what is the ESRI, who's in it, and who's who there, and what do you do there?
Thanks, Annette, and thanks very much for the invitation to talk to you today. So the ESRI, the Economic and Social Research Institute, we're an independent research institute based in Dublin, in offices in Dublin, and we've got about 100 staff. So about 70 of the staff are research staff, so economists, sociologists, psychologists, other social scientists. And really, I suppose, our mission is to provide evidence for policy. So we work across a number of different research areas. So you mentioned that I work in the area of health and quality of life, but we've got 9 other research areas. So things like macroeconomics, the labour market, education, social inclusion. So there's teams of people that work on various research projects on those themes. But I suppose in practice, we work across a number of those themes. So there's lots of links, I suppose, between research in these different areas. And we do lots of work for government departments and state agencies. We also do some commissioned work as well. So we get funding from, for example, the Health Research Board as well. So a variety of funders and sort of agencies that we work with to provide evidence for their work.
Okay. And how do you determine this? That sounds like a lot of funding streams and a lot of commissioned work across all of those agencies. How do you prioritise what you'll do?
I suppose our starting point is we have a research strategy and a strategy more generally, which sort of sets out our plans for research and for evidence over a sort of a 4-year period. So that very broadly sort of sets out the areas of work that we have capacity and sort of expertise to work on. How the research programmes or research projects then get determined is often government departments or state agencies will come to us and they'll say, we are developing a new strategy in a certain area, but we really need the data to be able to understand the types of issues and things that we should be looking at. So often we'll start a research programme and there'll be a steering group and we'll sort of determine in a sort of a very two-way sort of conversation over a number of years the bits of research that we'll work on. In other areas, what happens is, for example, we do a lot of sort of academic research. We're reading articles, we're reading journal articles, we're going to conferences and seminars, and we often get ideas for sort of interesting questions or interesting pieces of research. So sometimes we will go looking for funding for those pieces of research. So, for example, I mentioned the Health Research Board. They often fund us to do research in the health area. So we come up with a sort of a programme of research and a number of different ideas. So there's a sort of a number of different ways in which we fund our research.
Different streams. Okay, thanks, Anne. So, Anne, you mentioned data there, and I suppose we hear a lot about data, and throughout this Inclusion Health series and both the webinars and the podcasts, people have been mentioning stats, and we've heard a lot of the experts talking about reports and stats and demographics and all the rest of it. And we also hear that from the ESRI on the radio when we hear them in media interviews. My question is, what is it about data that's so important? Because people would say, sure, we knew that. There's nothing new here. We knew all of this. Isn't that the different reports, the tailors and all of those? What's new here? So why are we collecting this data?
It's a great question. And I think, I suppose from the perspective of how we work at the ESRI, we do quantitative research. So really data and statistics, that's our bread and butter. That's our daily work. So I suppose just to give you a bit of background on some of the data that we use and how we use it. So I suppose we use data from a number of different sources, and different data sources have their strengths and their weaknesses. So One particular source that we would use a lot is survey data. So we would use data from growing up in Ireland, for example, from Tilda, the Irish Longitudinal Study on Ageing. And they're really powerful sort of data sources because you get really good information on sort of multiple aspects of people's lives. So you can look at sort of links between different factors. We also use, particularly in the health area, we use data from administrative data sources. So some of your listeners may be, filling out the hospital inpatient inquiry forms, the data from the National Perinatal Reporting System. So we would use that a lot in health research. And then we also do collect our own data from time to time as well. So particularly for some of the research in behavioural science, where we're looking at experiments and randomised control trials, we will get people to sort of do experiments and we collect data that way. But I suppose why these data sets are important and why we think they're really, really valuable for the work that we do is I think often, we have a sort of a preconceived notion, or we might sort of be basing our information on sort of anecdotes or our own personal experience. But what these data sets give us is kind of that national picture, or the sort of average picture. And also, as I mentioned, with the survey data sets, you can look at sort of links between multiple different factors. And I think often it's underappreciated that, even just setting the scene can be really powerful in terms of sort of changing policy and changing sort of practice. So one good example is some research that was done based on the Tilda survey a number of years ago. So as part of the Tilda survey, people come in and they do a health assessment. And one part of that health assessment is timing how quickly they can walk. And timing how quickly they can walk doing different tasks. So, they had to count backwards. So they were doing a cognitive task. They also had to carry a glass of water. So they were doing a sort of a physical task as well. And what they found was that, people had a sort of slower walking speed as the tasks got more complex. And actually what they found as well was that the settings for road crossings, so pedestrian road crossings, weren't consistent with this. So for older people, the way the setting and the timing was set for crossing the road, it didn't give people enough time based on this data on their average walking speed. So that led the Tilda team to talk to Dublin City Council in the first instance. And they were very interested in this. They didn't know this. They had just used sort of international norms and setting these timings on pedestrian crossings. And it led them then to give extra time for pedestrian crossing. So I think that's a really good example of something where you might have thought you knew what the answer was. The data shows up something different and it leads to a change that's positive and beneficial for people.
Okay, that's really interesting. So our little green man, the length of time that he stays green dates right back to data that you have collected. That's right. Really amazing and something I did not know. So thank you for that example. And just you mentioned Tilda there and growing up in Ireland, and I think they're the reports really that people would be the most familiar with, I guess, is the ones who hear the most. I know it's great to hear the different reports coming out on those every year. It's always good to see what's happening. And bringing it back to this Inclusion Health series that we're doing and the groups that we have been hearing about and learning more about and that whole area. And I just want to list the groups if you just indulge me for a minute. So the groups that we've been looking at are poverty, addiction, homelessness, intercultural health, traveller, Roma, disabilities, LGBT, coercive control and domestic violence. And one of our previous podcast speakers mentioned that sometimes it's not that easy to collect data from those groups. Can you just talk a little bit about that maybe?
Yeah, no, it's a real concern, I think, often with survey data. So for very marginalised groups, so I think that the homeless population is probably the best example, survey data sources often will not be capturing them. In terms of sort of other groups, so you mentioned like the disabled population or LGBTQI population, they sometimes are captured and they can be captured in these surveys. But I suppose the issue sometimes that we have is that the sample sizes can be quite small. So if you start to, for example, look at gay or bisexual populations, the numbers can be quite small. So that sort of limits the inferences that you can draw from the data. So often we will look for administrative data sources as a kind of alternative to get information on those groups. So, for example, the census of population actually has been quite useful for us in doing research on sort of non-Irish ethnic groups, also on sort of the traveller and Roma population. But I suppose the disadvantage of administrative data sources like the census is that it's not necessarily, its main purpose is not for research purposes. It's obviously for administrative purposes for the state in terms of, deciding about services and delivery and demographics. So you might not get the sort of full information on health or socioeconomics or the sort of social circumstances of those groups, which you would really like to be able to probe. So I think it all points to, having as much data as possible. And I think often with these groups, there can be no substitute for doing maybe focus group research or more qualitative research with these groups to try and enhance, I suppose, the statistics that you do have from survey and administrative sources.
So we were talking there, Anne, about data sources and where we get the data. And you mentioned about homelessness and how challenging it can be to source data from maybe homeless group or other groups that we would have looked at in the Inclusion Health webinar series. So have you any thoughts on how data could be gathered, or how can we overcome this?
Yeah, I think it's a real challenge, and it's something that we're very aware of when we're doing research on marginalised groups, because often the starting point for a survey is that you need a residential address before a survey interviewer will contact you. So I think often in trying to source data on homeless populations, we would be trying to rely on service providers, so people who provide services to homeless individuals. But I think, there's quite a multitude of service providers that are interacting with the homeless population, and they're obviously collecting their own data, that's useful for them in trying to plan their services and look at the profile of people that are using those services. But I think they're probably not coordinated, or they're not harmonised, and they might be collecting different types of data. There can be challenges in terms of trying to link up data sets. So, we don't have a unique patient identifier just yet implemented across the health service, for example. So I think that creates challenges in sort of linking up other sources of data that we might be able to use for the homeless population. But I think more broadly, this highlights the issue with using administrative data sources, that they're not collected for research purposes in the first instance, and that's understandable. They're used by the agency or the group that's collecting the data for their own work in the first instance. But often they will use sort of different definitions or different measures of key concepts. So one example is across different administrative data sets, they really differ in how they capture data on sort of nationality, citizenship and ethnicity. So some data sets, for example, like the National Perinatal Reporting System, will capture data on the country of birth of the mother. But that obviously won't reflect ethnicity. It can be quite different. Other data sets, for example, might have data on citizenship, but that again is not tied up exactly with country of birth or ethnicity. So I think, data sets like the census, which have all three, the country of birth, citizenship and ethnicity, are really powerful because you can sort of delve into these different patterns. So I think it's probably a plea to, as far as possible, to try and make sure when we're collecting these data that we sort of have common definitions of these concepts and we're using common measures, because that would really sort of enhance the power of these data sets, particularly if they're linked together.
And are you a group that can use census data, or do you have to apply every time to access that data?
Yeah, so we apply, so we have a sort of a steady stream of requests to the Central Statistics Office for a lot of their data. So they're probably the main data provider that we would interact with. So we apply to the Central Statistics Office for access to data like the census, the Growing Up in Ireland data, the Labour Force Survey, lots of other data sets that we use that are collected by the Central Statistics Office. But then we apply to other data providers. So, for example, the HIPE data, the Hospital Inpatient Inquiry, and the National Perinatal Reporting System, we apply to the Healthcare Pricing Office. They're the sort of data custodians for that. So we sign agreements in relation to, how we're going to store the data, how long we're going to store it for, what purposes we're going to use it for, the sort of controls we have in relation to who can access it, what sort of outputs we're going to generate. Often we have to send our outputs to the data provider first to make sure that we're, for example, not identifying a particular individual, for example. You want to ensure that the data are anonymized appropriately. So there's quite a lot of controls in terms of our use of the data. We have to sign agreements. So we don't actually have we don't really collect any of the survey data ourselves. We apply to the various data custodians for access.
Okay. And just one more comment on the census before we leave this area. But did this, we're talking about how challenging it is to get this data from these different groups. Does the census, is it equally difficult for the census, or did every single person that was supposed to complete the census complete it?
So I think that we use the census quite a lot. I think it's a really valuable source, and I think Ireland is quite unique in that the census is every 5 years. In a lot of countries, it's every 10 years. So we have quite frequent data from the census. But I think there's a broader issue, I think, around people engaging with surveys. We've definitely found it with Tilda and growing up in Ireland that there's a bit of fatigue, I think. People don't answer their doors anymore, in terms of telephones. Everybody has a mobile as opposed to a landline. So there's particular issues, I think, in trying to get people to engage with surveys. I think for the census, the CSO do a really great job in trying to encourage people to participate. And I think there have been discussions around trying to make it easier for people to participate. So maybe putting in place an online opportunity to fill it out online like they do in lots of countries, as opposed to, an interviewer having to leave the form at your home and come back a month later.
And are there any social inclusion projects ongoing at the moment in the ESRI?
Yes, so we actually have a dedicated research area for social inclusion and equality. So some of my colleagues would do research on the sort of main equality groups. We also have a big program of research which is looking at migrant integration at the moment. So looking at various aspects of that across different migrant groups. But I suppose it's a common cross-cutting theme, the issue of equality and inequality. So, for example, people working in my team in health, in education, in demography, in the labour market, for example, they would all work across, and look at particular groups that maybe are disadvantaged or marginalised. So I think it's a particular research area, but it's also a sort of a cross-cutting theme across a number of other different research areas in the Institute.
Okay, so there's crossover then between your social inclusion equality and then into health as well. So they all, and I think education and all of that.
Exactly, yeah. So a lot of the work that we do on sort of children and young people, for example, would very much have that kind of lens or that focus. So we would look at, for example, we did a recent piece of work which was looking at the housing situation of children and young people, not only inequalities in terms of their housing conditions, but also the potential impact of poor housing conditions at different stages in childhood for outcomes then as they move into adolescence. Okay. So I think that sort of lens or that sort of theme really cuts across a number of different research areas.
Just talking about the health service itself now and looking at the social determinants of health, really, what are your thoughts on the structure of the health service and how this helps the groups, again, that we're looking at, these underserviced groups?
Yeah, so I suppose as a personal note, I started my career really looking at the impact of sort of barriers to access to health services on health and healthcare utilisation. But I suppose as I read more and I delved into the data, it became clear to me that it wasn't just sort of access to services that was important. It's what you're talking about, the more social determinants of health are really important too. But I think that's not to say that, access to services is not important. And I think what's been really interesting in the Irish case is obviously we don't have a universal system of access to primary care. So, if you want to go to see the GP and you don't have a medical or a GP visit card, there's significant financial cost associated with that. And that can be a real barrier for certain groups. Now, obviously, there have been moves over recent years, and Sláinte Care has a commitment to introduce universal-free GP care at the point of use, and I think that would be really, really positive. But I suppose some of our research has highlighted that there's not necessarily only financial barriers, there can be other barriers too. And I think for some of the marginalised groups that you're talking about, these can be nearly as important. So one of the examples I'll give you is we did some research a number of years ago into early life inequalities in mortality. So this is like perinatal mortality, so mortality in the first week of life. And we were primarily interested in looking at socioeconomic inequalities. And indeed, and very depressingly, we found that the children of mothers who were in more deprived socioeconomic circumstances were significantly more likely to die in the first week of life. But also what we found was that the children born to Black African origin mothers were also significantly more likely to die in the first week of life, even when you took into account their socioeconomic circumstances. Now, when you think about access to maternity services, in theory, everybody has access under the mother and child scheme. But I suppose there's potentially other non-financial barriers there that are acting as a barrier to accessing services. There's also sort of wider issues around discrimination and sort of the social determinants that could be playing into that relationship. So I think access to health services is really important, but as you mentioned, it's not the full story in terms of understanding these inequalities.
Yeah. I suppose that kind of brings me around then back to the ESRI and the influence of ESRI on policy, which should eventually translate into practice and maybe change that interface at the front line. So can you talk to me about that, but maybe how policy translates right down into practice?
Yeah, so I suppose the way I think about it is we do it in a number of different ways. And obviously, we make recommendations, or we term them implications for policy. And I suppose it recognises that there's lots of other considerations that, policymakers have to take into account. They have budgets and competing priorities. But sort of taking a step back from that, I think about it in terms of sort of three different ways that we kind of influence policy. So the first is sort of the issue around sort of setting the scene or providing information on issues or things that you might not know the full story. So the example of the tilde and the green man and crossing the road, I think, is a good example there. But there's also where we provide evidence is sort of evaluating policies that are already in place. So often, a policy will be put in place, but I think it's really important to try and understand and to evaluate whether it's achieved the objectives that it was trying to achieve. So another example, again, using tilde is we did a bit of work a couple of years ago where we looked at the rollout of the smoky coal ban. So this was rolled out in sort of successive stages across different areas of the country. And we could use the tilde data actually to look at the impact of that on respiratory health and outcomes in the older population. And we found that indeed it reduced the incidence of respiratory disease. So I suppose that just reinforces the importance of that policy measure. And we now know that there's a nationwide smoky coal ban that's been put in place since the end of 2022. But I suppose another area that we influence policy is sort of before policies are implemented or designed. And it's trying to what's called like pre-test a policy intervention. So you might have an idea that you're going to put in place a policy to do something, but you don't know exactly what it's going to look like or how it should be organised. So one of the recent examples that the behavioural science team here have done is working with the Department of Health on their calorie posting legislation. So it was paused during the pandemic, but the idea was that you should put mandatory calorie posting on restaurant and food service outlet menus so that people have better information to make healthier choices. But they weren't quite sure how to do this, so where should you put the calorie information? Should it be in a different font size? Should it be in a different colour? And how would people react? So what they did was they ran an experiment, so a randomized controlled trial, and tried different versions of menus, followed up in terms of what people were ordering and also what they were eating, and found that a certain design was most effective in terms of reducing the calories that were ordered and the calories that were consumed. So I suppose that's a really good example of something where there's a kind of a pre-test, or before a policy is implemented, we use the data to try and understand what's the best way of implementing something.
Okay. And in terms of that example and the Green Man example, is there a length of time then, or does it vary, the length of time between gathering the data and implementing into practice?
Yeah, so I suppose this is something that often can be a bit of a tension between researchers and policymakers. So, they will often, policymakers will work on a relatively quick cycle and they want answers immediately. But I suppose the nature of data is that it takes time to collect. And particularly if you're looking to evaluate the impact of a policy that's already been introduced, often you need longitudinal data. So you need repeated measurements on the same people. So the data that we used for the smoky coal analysis, for example, that spanned a 10-year period. So, you're potentially waiting a long time to be able to evaluate a policy. So I think it's certainly something we struggle with, and you have to be patient, I think, in working in this area. But I think the pre-testing of policies, that can be done a bit quicker once you have a very clear question as to how the study should be designed.
So thank you for that, Anne. From my own perspective, so we're from the Centre of Nurse Midwifery Education and work at the HSE, and we're based in Mayo. So if we say we had a project that we wanted to proceed with, and there was a data gathering element to that, could we contact you about that? I'm talking about a health project now, or something to do maybe with social inclusion or trauma or whatever. Would the ESRI have a role in that, or how could we link with you on that?
Yeah, so absolutely. That's something that we would do quite frequently. So people will approach us, they'll have a project or a research need or a sort of a policy analysis need. So we'll sort of discuss it with the group in question, and I suppose see where we might be able to contribute. But I suppose what you're talking about is, sort of clinicians coming to us, and we would often collaborate that way. Obviously, we're social scientists, we're very skilled in data analysis and policy analysis, but we often, we don't have the clinical expertise to be able to, understand maybe certain patterns in the data. So I think we do collaborate quite widely in a lot of what we do. So yes, the answer is yes. If people want to contact us, please do.
Okay. And what would that look like? So would you share data or just advise, or what?
So it depends on the project. So, for example, if somebody was coming to us and had a data set that they needed to analyse, I suppose there are procedures that we put in place in terms of, data security and ethics and access to the data that we would put in place, I suppose, that protects, the data subjects and also ensures that the data has been analysed appropriately and transferred. But I suppose more generally, if we're thinking about sort of research questions, often it's a bit of a conversation that happens over time. You'll sort of think about, what sort of questions you might want to answer, what sort of data might be available to do that, what the timeline is, what the budget is, what the outputs potentially would look like. Are you going to do research papers, research reports? Are you going to present to seminars or conferences? So I think it's, it's a longer conversation that happens, but I suppose the initial contact is an idea and we kind of thrash out how that might work in practice. And
in terms of your funding, Anne, where do you get your funding from?
So we have core funding from the Department of Public Expenditure and Reform of about 25% of our income. And that mainly supports our macroeconomic forecasting work. And then the remainder is really from public sources, comes from government departments and state agencies, and then sort of funders like the Health Research Board in the health area. But I suppose the main sort of principle we have in terms of our funding is that it's generally public because we have a public good role and we're supposed to be informing policy for Irish society and economic progress. So we publish everything that we do. So in that sense, we generally wouldn't have funding from private sector organisations, who might be interested in a piece of research, which they're trying to use for their work, but they don't want, let's say, competitors or other companies to see. So we would do generally only work with organisations where the research is available more broadly and it's for others to use as well. So not just the person that's funding the research.
So, even though I could go on and talk a lot more, but I suppose we're coming to an end now, but just one thought from yourself just before we wind up. Have you a vision going forward with regard to research specifically in the area of inclusion health, or what do you think? Where should we be focusing our efforts there?
So I think it really goes back to what you were talking about before, is trying to capture and make sure that we characterize these groups accurately and appropriately, so that we're able to design policy interventions that improve their outcomes. So, coming from the perspective of a researcher who uses data, I would be really trying to call for that we, as far as possible, try and include these groups in the various data that we're collecting, that we harmonise measures that we're collecting, so that if we need to sort of link data sets together, we're able to do that. I think linking data sets together can be really powerful and can give you extra information. But to do that, it requires, for example, that you have an identifier that allows you to do that. So I think it's really trying to enhance the data landscape. And I know there are bodies and there are groups that are trying to do that. And the CSO, for example, trying to harmonise measures. So I think it's really, it's trying to, I suppose, strengthen the data capture environment. Yeah.
So to be aware of what's been collected and what's not been collected from these groups as well. Okay, well, Anne, thank you so much, Anne. It's been an absolute pleasure speaking with you this afternoon. The big piece for me, I suppose, is you have taken the social and research element of the ESRI for me. I would always have said it was economic and stats driven, but you have proven to me that it is not, or shown me that it is not. So thank you very much for that, Anne.
Thank you, Annette. It's been a real pleasure too.
Today's episode was produced by Ms. Mairéad Loftus, Specialist Coordinator Nurse Tutor, and Ms. Cora Appelbe, Specialist Coordinator Nurse Tutor from the Centre of Nurse and Midwifery Education, Mayo, Roscommon. And special thanks to Mr. Alan Meaney, Radio Producer. And I'm Annette Cuddy, Director of the Centre for Nurse and Midwifery Education, Mayo, Roscommon. Thanks everybody for listening to our first podcast series on inclusion health. Listen out for Series 2, where we will hear the voices from the margins.